Good afternoon. I'm very happy to chair this session, sponsored by Straumann. My name is Anton Sculean. I'm the chair of Europerio 11 and also the Secretary General of the EFP. So we are going to address an important issue in periodontal regeneration, namely enamel matrix proteins and a specific product called Emdogain. And this is not a new product, but it is the product and the material with the longest evidence. And you can see 30 years of evidence. This is huge. This is fantastic. And yesterday evening we had a celebration together with the inventor, Stina Gestrelius from Sweden, inventor of the product. And I would like to give you a short summary about my journey, because I started to work with Emdogain in 1996. I treated my first patients, but I was in contact with this product already in 1994 when I was a postgraduate student in Denmark. So what are we talking about? We are talking about the cocktail of proteins. It's not only one single protein, but it is a cocktail of proteins that has an important role during tooth development, and especially during cementum formation. And you can see that the first publications on this specific topic were two IADR abstracts in 1976 and 1975 by Slavkin and co-workers. So what is this bunch of proteins? We have in fact a kind of growth factor-like proteins that are secreted during tooth development, and they are isolated from this area of the enamel matrix. These proteins have been detected on the root surfaces and in the cementum, and that's why the concept was born by Lars Hammarström and colleagues, who was a professor of oral biology at Karolinska in Sweden. So when we look at the publications, we have roughly 2,000 plus publications in PubMed about enamel matrix proteins. And we know nowadays that we have a strong biologic effect, especially on periodontal ligament cells. And when periodontal ligament cells are getting in contact with enamel matrix proteins, then they are going to secrete certain growth factors like TGF-beta or PDGF, platelet growth factor, and they have an important role in soft tissue healing, but also some BMP-like functions. The role is not only on periodontal ligament cells, on bone cells, but also on soft tissue cells, gingival fibroblasts, for example. So this was our first study, because we started with my very good friend Nikos Donos, who is now professor in London. We started with our first study in animals, and we were able to demonstrate, you see already many years ago, 25 years ago, that following the use of enamel matrix proteins, we have formation of cementum on the root surface, periodontal ligament, and bone. And to the right, you can see the high magnification of a newly formed cementum with inserting collagen fibers. At the beginning, I was quite skeptical with this concept, because I was trained with GTR, guided tissue regeneration, by my mentor, Torkild Karing. So we couldn't imagine how a fluid may indeed promote regeneration, because dentists are always used to place something in a hole, an amalgam or a composite, and then everybody's happy. However, periodontology doesn't work like that. Myself, I was also skeptical. You can see here one of my first cases, a patient that I treated in Germany in 1996. And you see this patient was referred to me for periodontal therapy. You see this huge vertical and horizontal attachment and bone loss. I opened the flap, and it looked like that. It was a huge defect reaching almost the apex. Luckily, it was a canine, so it didn't have a mobility. And in fact, I applied the material. I was saying to myself, okay, if the material will function or has a potential, it should function in such a case. And then after 4 years, the tooth was still there. And then I was able to convince the patient to have a re-entry. And you can see this bone fill that took some nice photographs and hard measurements. Nowadays, it's not so easy to do these kind of studies. And then I treated more than 2,000 cases in different studies. And let me show you what we can achieve with this material. You see here one patient that I treated already in Bern, many years following my journey with Emdogain. I opened up and you can see a huge defect reaching almost the apex. It is a very, very important tooth for this patient because she is a quite young lady, and if she would lose this tooth, we have a severe problem. So I applied the material without any bone graft. Then I closed the flap, and I waited for the healing. This was about 7-8 years ago. We have a slight increase in recession, but you can clearly observe that we have, after 5 years, a nice increase in the bone level, and the teeth and the tooth, this one is still there, and the patient has a quite nice outcome. So what is happening on the root surface, just to set the stage for my colleagues who will speak later. You see, already in 2005, we looked at the newly formed tissue on the human root surface together with my good friends Peter Windisch and Dieter Boshart. And on a human root surface, we have already, after 8 weeks, formation of cementum. And cementum forms much faster when we have Emdogain on the root surface. And you see this area of mineralized tissue. This is the darker staining. And if I look at one cell under the transmission electron microscope, I can see the cytoplasm that is full with ribosomes, rough endoplasmatic reticulum, and you can clearly see the collagen fibers that are released from this area. So we have a so-called biologically modified root surface. And then we did a number of studies looking at the histologic aspects and the clinical aspects with this material. You see only one example, and you can see here the date of the surgery. It was 1997 when we did it together with Professor Windisch. At that time we were not professors, but you see here we applied Emdogain on the root surface, and then after 6 months we took out the root, you see, together with the entire tissues that surrounded this root. And what we observed is formation of cementum on this root surface. Here you can see the apical notch. We have periodontal ligament, we have bone formation, and we have the cementum that was growing up in a coronal direction almost to the top. And at a high magnification, you wonderfully see the bone, the periodontal ligament, and the new cementum that was very nicely deposited on the old cementum. So what is the clinical relevance again? You see one example of a quite advanced periodontal defect, and here again I opened up, cleaned the defect, applied only Emdogain, and you see at 5 years very nice outcome. So I increased the bone level with about 6 millimeters. So when we look now at the so-called EFP S3 level guidelines, and we had a quite nice supporting literature on regenerative therapy, analyzing more than 1,000 patients and more than 1,180 teeth that were treated with different regenerative approaches. And one of the important conclusions was that the best material supported by the evidence for periodontal regeneration was definitely Emdogain, due to the biologic background, to the histologic background, and also to the clinical relevance coming from randomized controlled clinical studies. And this is only one decision tree model that I apply for my patients, And in many cases, I either use Emdogain alone in a contained defect, or I combine Emdogain with a graft. Let me show you some clinical examples, and you see already in 2008, that is many years ago, I published with my group 10-year results. So we were one of the pioneers in this field, and this was one of my patients that I treated in Homburg at that time in Germany, and she had an aggressive periodontitis, and after 10 years she still had the teeth in place, and we can clearly see the coronal growth of the bone. Or another case with very deep defects that many colleagues would extract, you can clearly see we have a stable situation even after 10 years. Now when we look at the furcation therapy, periodontal regeneration is possible, but only in class 2 furcations, and furcation involvement is definitely not a reason to extract the teeth. And also in furcations, I use this concept. Either I use it alone or I combine it with a bone graft, and I would like to show you only one case. And in this case, you see one patient was a young lady that was roughly 22 years old at that time, and you can observe this first molar with a huge vertical and also horizontal attachment and bone loss, including also a class 2 furcation involvement from the palatal direction. And when I opened up, you can see this defect configuration. We have, in fact, a so-called non-contained defect. And what can we do in such a young patient? Of course, maybe some colleagues would extract the tooth, will build up, place a nice implant, or maybe some resective treatment. However, in such case, I always want to improve the tooth prognosis. And you see here the combination. I use Emdogain on the root surface and then a layer of autogenous bone and also collagen membrane in order to do my very best for improving tooth prognosis. And when I look now at the outcome after 10 years, we have a wonderful healing, and I managed to maintain this tooth, and you can observe that this defect is completely filled, and I gained roughly 12 millimeter of clinical attachment level. And another case where we had a recession, and this technique of the laterally closed tunnel was described together with Dr. Allen from Houston. It's a very simple technique. This lady had an accident. You can see this huge defect reaching almost the apex. So what I did here is just to condition the root surface. Of course, I prepared a tunnel, mesially, distally, without any vertical releasing incisions. And then I used Emdogain on the root surface because it's a huge defect. I want to regenerate the periodontal ligament, the bundle bone, and also the soft tissues. And I like to combine Emdogain with the autogenous graft in order to increase the vitality of the cells and also to booster the healing. And now when I look at the closure, it's nicely closed. This is the donor site at the palate, and when I compare the baseline situation with the outcome after roughly 2 years, we see a complete regeneration of the soft tissues, no residual pockets, and also the aesthetic outcome is very appealing. So let me come to some conclusions. This was just the introductory part, indicating that at present, the data show that Straumann Emdogain is the best documented material for periodontal regeneration, and it can be recommended for the treatment of intrabony defects, class 2 furcations, and gingival recessions. And of course, now we have 2 very talented colleagues who will show us their concepts and their cases, because, I mean, it's very nice to promote this concept, but we need also the younger generation to be aware that biology doesn't change, but we have, in fact, to apply it in the right clinical indication. And now I would like to thank you for your attention for this first part, and I would like to call on stage the next speaker. And the next speaker is a very talented colleague, Dr. Serhat Aslan, and he is one of the rising stars coming from Turkey, and he has invented wonderful, novel surgical technique. So the stage is yours.
Thank you, Tony. Thank you so much. Thank you. Especially hearing from the legend of the Enamel Matrix Derivative and all the periodontal regeneration concept is a privilege. So, I would like to start the impact of the flap design, how we are going to deal with flap design in the enamel matrix proteins. And better to pass like that. So, recent EFP guidelines, as Professor Sculean mentioned, we have clearly a roadmap in the management of the intrabony defects. Definitely, we should go for the regenerative periodontal surgery after the completion of the step 1 and 2. And also, we have to stress the importance of the soft tissue maintenance in the defect-associated papilla. So, we have a lot of variation in the application of the flap design for this very delicate area, because normally the tooth is our friend, but vascularization point of view, it acts as an enemy because it interrupts the continuity of the vessels. So in time, you can clearly see the whole story started from Henry Takei in 1985, and I have contributed with the entire papilla preservation. And we have published, of course, we would like to make in a scientifically evidence-based surgical technique. That's why we contribute everything in a precise way. But to be in short, entire papilla preservation is the protection of the blood clot to further enhance the predictability, because most of the times in the beginning of the 2000s, we are going to have some issues with the membrane exposure. Then the fourth generation, before like the non-resorbable barriers, resorbable barriers, beforehand we had the millipore filter which was disinfected. Fourth generation is the biologics, and now growth factor is the friend of the clinicians. So why I am insisting on performing and avoiding an incision over the defect-associated papilla? Because we are going to protect the regenerative space by its nature with its own sharp A fibers without any additional suturing on that. And if you have a very high supracrestal component, and if you cut the papilla, you have the possibility to have a papillary collapse. And I brought you this case. This case was started with a dentist friend of mine. He did the root planing within the same area. Probably he damaged the root surface. And you can clearly see that the 14 millimeter, 9 millimeter, and we are super lucky in the distal part. We have 3 millimeter that will indicate an incision shifting from the defect-associated papilla to the line angle of this area, because we don't have any attachment loss on the distal aspect. And in this, of course, despite I did non-surgical treatment for that area, it is impossible to resolve because he created the hard tissue defect in that substance you will see in a minute. So I never perform surgery if you have this kind of bleeding and a little suppuration. But this was a very urgent case of mine. And I cut to the distal papilla. I never performed to the divergent incision. You see that in a perpendicular line, we start from the most coronal part, and we ended up within the same perpendicular line. If you have a divergent one, you're going to traumatize during the reflection and lateral stretching of the flap. And also, we are going to use our mucogingival skills. You're not going to place your periosteal elevator and just reflect the buccal flap in a traumatic way. You're going to use your 15C blade very gently. And sometimes I hear, oh, your technique has a post-surgical gingival recession. You may traumatize the buccal soft tissues. We need to respect the incision line. So protection of the interdental papilla doesn't mean that you can traumatize and harm the buccal soft tissues. That's why it is important, and you can clearly see that how hard it is for me to make it an even surface, because he planed only one area, and it takes really time consuming. You have to use your sharp gray sucurette to create a biocompatible root surface, and you can clearly see. Now you can apply your biomaterials after decontaminating the root surface. To make it a smooth area, I'm going to apply some of my diamond tips, And in this case, we are going to apply first the Prof gel for 2 minutes, 24%, and after drying the root surface, we are going to apply Enamel Matrix Derivative onto a dry root surface. Because we know from the studies from the group of Tony and also Rick Myron, the precipitation rate of the EMD is highly decreased in the presence of the blood. It still has some precipitation, but it is not as we want it. And in the case of the bleeding, we have to mix. We cannot apply directly to the root surface, but this is very important to emphasize. And for the suturing perspective, never start from the most coronal aspect. Because most coronal aspect, you're going to suture with a lot of flap tension. And we gradually and increasingly decrease the flap tension by suturing the mid portion of my single buccal vertical release. Then we are following towards the apical part, and last suture should be performed from the most coronal aspect by using the microsurgical suturing approach. So you can clearly see that we don't exert a lot of tension in the most coronal margin, and if you start from there, and if you tear this tissue, send this case to Tony to cover the recession. So, this is the wound closure, and I like really dynamic images besides the static images. This is the 7 days of wound healing. Since we shifted the incision line towards a relatively safer space, you can clearly see that we have a really nice primary wound closure, and this is the 1-year outcome. When you stick your periodontal probe inside, you see how thin line that we are walking towards the preserving the aesthetic in this case. Patient had the full crowns. And if you make a mistake to lose the papilla or exposing the margin, the connection of the prosthetic line within the tooth root surface and the prosthetic component, maybe you have to change the clinical crowns. And also I would like to show you the live image of the probing. You can clearly see that. I hope I create the attachment, but already Professor Sculean demonstrated the histologic evidence, which is I'm walking very confidently on that road. And also, let's underline one point. I didn't adjust prosthetically, or I didn't apply any aligner therapy, but just recapturing and closing the pocket, and hopefully it's a regeneration. You see that tooth realigns itself, hope not automatically, but in time. So, from a radiographic perspective, you can clearly see that the defect previously reaching the almost 1/3, and you can clearly see that even the periodontal ligament space, I hope, because we have methods, the best available evidence is the histology, but I cannot take. But we have also the CBCT for the implant purposes, and you can clearly see that the hard tissue reformation in that aspect. Good. Of course, I'm not here to promote my technique. I am going to discuss this case. This case was treated 10 years ago in a university setting and with a GTR procedure with a membrane and a grafting material, but 10 years after, it failed again. And of course, what you're going to do, you're going to first analyze the damage and the disease, and you can clearly see that we have trauma from occlusion. And if this is a hypermobile tooth, are you going to extract this tooth immediately? No. First, you are going to go back into the literature to clear roadmap for yourself. And in Sandro Cortellini's road, we can clear, I'm not interested in survival rate, because this could be deceptive. The regenerated tooth can get traumatized, right? So I am very interested, as a periodontist, is a close in the pocket. And you can clearly see that these hanging in the air, 3.4 millimeter mean residual probing depth, which is a good news for us. So I'm clearing my path. What I did, I just eliminated the occlusion. The tooth already had a root canal. So you can clearly see that we eliminate the vertical mobility, but of course you cannot solve the horizontal mobility. And in that sense, the defect morphology, forecasting the defect morphology is very essential. And if it is not indicated, you're not going to say, hey, I'm not going to incise the papilla. This is a circumferential defect, 360 degrees. But you can think still in a vascular perspective. I will come to you in a minute. I started the surgery performing the diagonal incision, 1999 Sandro Cortellini's simplified papilla preservation flap. And after the reflection of the buccal flap, please note one thing. I didn't raise the lingual yet. I am going to work. I am going to traumatize the vascularization only on the buccal aspects. And maybe I'm going to spend 3/3 of my surgery only from the buccal aspect, like in the single flap approach or the modified MIST style. And also, we don't need to forget the previous surgery's effect. You can clearly see that buccal flap also needs to be sharply dissected because you have a lot of granulation tissue still attached to your buccal flap. And sometimes we forget to evaluate the fate of the inside of the buccal flap. After this, I changed the angulation of the microscope. You can clearly see that we have small concavities in the distal part. There's a little bit of left calculus. It is impossible for me to clean, and I think even the most talented periodontists will leave some calculus, we know from our historical studies. Now it comes to reflect the lingual flap. Do you know how many minutes I have spent to clean the 3/3 of the root? And now I am going to reflect the lingual flap, because sometimes surgeons are really focused on the defect and then immediately reflecting the buccal, immediately reflecting the lingual or palatal. Why so? First, debride the buccal and then go for the lingual site. You can clearly see the defect going, and probably it looks like tonight Congress party, probably. The tooth is having some champagne, probably. And before applying the EMD, pre-prepared interdental sutures will help clinician a lot before the placement of the Biologics, Emdogain, and beforehand we are going to apply the EDTA gel on the root surface for 2 minutes. And after this, we are going to thoroughly rinse the area, dry the root surface, and I initially start from the lingual aspect, not to contaminate with saliva. We should protect the area. The assistant has an important task. And after this, your pre-prepared suture will help you to close. And please note that this site has almost zero keratinized tissue. Did you notice that? And we are going to check the pure contamination and also checking and also controlling the power of a minimally invasive flap. So, of course, you have to stabilize with the splinting method. This is a very primitive splinting technique. I'm still using it. And this was the baseline, and you can clearly see that we are going to resolve the defect. However, due to the concavities in the soft tissues and the lack of keratinized tissue, despite I closed the pocket, the patient has a constant, not a deep, but a profuse bleeding on probing. So in that case, of course, we are going to improve the keratinized tissue, and we are going to apply a free gingival graft. You can also use the partly epithelialized free gingival graft in that sense. We are going to prepare the recipient bed. We are going to use our compressive suture, and this is a very good stability of the area. So when we're comparing, and even the crown is placed on that tooth, the baseline, very, very deep probing depth can be resolved and maintained up to 3 years. So I will jump on to the gingival recession, and we have tons of causes, but main predictor could be the thin phenotype in that sense, and also we have a lot of contributing factors. But since we are going to focus on the thickness of the buccal soft tissues, we're going to use the biotype probe by Professor Testori and Rasperini, and in that sense, if the visible the probes, you're going to classify as thin. And also we made the study performing the coronally advanced flap alone without any addition of the connective tissue graft or the matrix. The overall data are in line with the classical literature on that manner, but we did subgroup analysis and discriminating between the subgroups of thin, medium, thick, and very thick phenotype. And the results getting dramatic. Because in the thin phenotype, the complete root coverage rate drops down to 25%, meaning that 1 out of 4 is success, 3 out of 4 is a failure in terms of complete root coverage. So which surgical technique to apply? So we are recently trying to bring the novel anatomic recession ratio in that point, and you can calculate this point if you have these stable 4 contacts, meaning that RT3 recessions is not the case. So you need this distal tip of the papilla, mesial tip of the papilla, and also you need gingival contacts in the line angle or along the CJ, and in that way, we need to train a little bit as a mathematician, because it divides the anatomic line measurements towards the gingival recession line. And you're never going to get the value of the 1, because the gingival line will always be shorter, anatomic line will always be shorter than the gingival recession line. So this is a case example. Although I have a very large piece of connective tissue graft, we applied a modified colon advanced tunnel, and you can clearly see that despite we have the really nice surgery, it is impossible to completely cover the root. It is an RT1 recession. And the anatomic recession ratio of 0.87 in an RT2 case, the distal papilla, we had a clinical attachment also in the distal part, we obtained a complete root coverage. So we basically pulled the analysis and we clearly demonstrated the correlation between the whole group, and also separately we analyzed the RT2 gingival recessions, and we concluded that if you have a higher anatomic recession ratio, it is positively associated with the root coverage outcomes in the tunnel and connective tissue graft surgery. So we also, of course, within the limit of this very limited sample size, 0.7 is my critical threshold to decide going for modified colon advanced tunnel or to traditional cuff. So I start as a mathematician. This is the measurement of the anatomic line. We divide this value. You don't need to standardize anything. You just need a frontal picture, and you're going to use the length of the pixels. And you divide this value, and we found that it's 0.57. Of course, this was before the laterally closed tunnel, and we are going to have the data also for the laterally closed tunnel as well. So I am going for the coronally advanced flap in this very, very challenging, no attached gingiva in that area. You see that the alveolar mucosa is completely mobile, very deep gingival recession. So we are going to perform our classical divergent incisions, 2 vertical releasing, 3 mm horizontal cut, deepitalizing the anatomical papilla, and also planing the root surface. You can clearly see that this is a very wide root surface. So we are going to plane the root surface, and after this, we are going to apply the Prof gel for 2 minutes, 24%. After this, we thoroughly rinse the area, drying the root surface. I like a very dry root surface before the application of Emdogain. And the precipitation rate of the Emdogain onto the dry root surface is the superior one. So we're going to improve the attachment, as Professor Sculean stated, because we want to create, we're not going to cover the root surface, we want the creation of the periodontal tissues, which is cementum, new periodontal ligament, and new alveolar bone. Of course, this was a zero keratinized tissue. Of course, it's very super thin. So we need to boost also the phenotype. So I applied a shield-like connective tissue graft. The patient has a really nice tuberosity. I had an even thickness of the tuberosity in that area. We stabilized with a resorbable suture, and in that sense, we stretched laterally the most apical part and suturing onto the periosteum, so we have verticalized and minimized the dead space under this coronally advanced flap. And this was the beginning. You can clearly see that how deep the recession is, and we're going to close, and the blending of the tissue is really, really aesthetically satisfactory. And when we can superimpose these 2 images, you can clearly see that very deep recession, despite the lack of keratinized tissue can be regenerated using the connective tissue graft plus Emdogain. And also, from another perspective, you can clearly see that the outcome can be maintained over time, and this is a really great shot from the lateral aspect, is a sleeping tooth. So, in short, we need improved flap design despite all of the thinkings that we have. Professor Sculean clearly stated that we need to think and we need to dive into the biologically thinking. Don't get fooled by this technique. We need to remain into the biology as stated by our dear masters. We need to use biologics respecting the basic principles. We should stick onto that. And last but not least, if you want to reduce the risk of wound failure, maybe if it is indicated, you may use the avoiding papillary incision on the defect-associated papilla. And with this, I'd like to thank you for your kind attention.
Thank you. We will have some time for questions at the end. So I would like to call upon stage Dr. Meizi Eliezer. And she will present her concept and her cases. Meizi, please.
Thank you so much, Tony. Thank you for coming here this afternoon. I'm really excited to be here with you and to show you and present for you today my cases. This is really a big honor, and I just want to say that I was educated in Bern University under the supervision of Professor Anton Sculean, and over there I acknowledged and also my skills and my knowledge to come and show you today the cases that I'm going to present. Yeah. It's not working. Oh, thank you. I want to declare that I have no conflicts of interest and to tell you there is no Photoshop on my lectures. What you see is what you get. And the residents that I'm teaching in Timisoara University know that we take the pictures and we apply it into the presentation. There is no Photoshops, not in the X-ray and nor on my others clinical pictures. So what is for you periodontal defects? For me, periodontal defects is everything that you're going to see now. It's going to be present in recessions, multiple recessions. It can be present everywhere when we have a deep vertical defects. It can present when we have horizontal or vertical defects, or maybe endo or perio lesion, perio-endo lesions. We can be a single recessions. It can be also vertical furcation. Also, when we have periodontal cyst, is also a periodontal defect. And when we have external root resorption, for me, it's also a periodontal defect because the cementum is ruined, and cementum is very important part for periodontal regeneration and for periodontal apparatus. This is a very late case that have come to my clinic. I have only 5 months documentation due to the fact that the patient had to leave for his homeland. And I had to close this documentation and send the results to the doctor, to the periodontist that's going to treat him in his homeland. So this is how the patient came. You can clearly see the vertical and horizontal defect. I was suspect that maybe it's an endoperio lesion, but due to the fact that this lesion was, this tooth was vital, then it wasn't an endoperio lesion. And you can see the periodontal cyst. He had a pus formation, bleeding on probing, 15 millimeter of probing depth, and I was treating this patient. And I want to show you the results. Yes, you can see recession. So I took photography, and I also took an X-ray. And when I see the X-ray, I was amazed to see how much bone this patient got. I haven't probed it because I learned from my professor, Tony, that he told me, do not probe. Only after 6 months you're allowed to probe. So I didn't probe, but I did took an X-ray to send it to his periodontist in the homeland, and I was very happy to see what I saw. And this is all due to the fact there is a periodontal regeneration. For this to understand what kind of healing we're going to have, we have to know this slide. This slide is an important slide for everybody that wants to know what kind of periodontal healing we can get. So first of all, when we all opening a flap and closing a flap, we're going to get what? Reattachment and long junctional epithelial. This we all learned. Sometimes we're getting ankylosis and root resorption. This is not something we like, but we can get it. And yesterday there was documented here in the panel that we can get it sometimes after periodontal regeneration. Suddenly we have an external root resorption, and we're asking ourselves why. In my opinion, I think because it's an scaling and root planning when we're doing the periodontal regeneration. In my eyes, we have to be very gentle on the root surface. Yes, take out the calculus, for sure, but to be very aggressive can cause to the external root resorption. So the other periodontal healing is when we have periodontal regeneration or new attachment. What is that? New attachment is when we get a cementum and PDL, and when we have a regeneration, you can add the bone, a new bone formation, a new PDL and a new cementum. This is a full regeneration, and we should aim today to get it, and we can get it. And hopefully I'm going to show you some of my cases, how I got it. This is an Emdogain. In order to get periodontal regeneration, we need to apply periodontal regenerative material. Otherwise, where can we get a new bone? How can we make the cells of the PDL to be proliferate and make a new PDL cells, a new cementum? Emdogain, 30 years, as you can hear here in the panel, 30 years of documentation. For me as a researcher, is very, very important to see the research behind what I'm using in the clinic. This is how I also can convince my patients to use this material and pay for it. Emdogain, 30 years. They started from an enamel, from animal research, and grow, lots of research, randomized control trials, and meta-analysis that at the end shows us the results of this material. In 2016, it was 20 years for Emdogain, and Rick Myron and Professor Anton Sculean and colleagues published this documentation. What is the clinical indication for Emdogain periodontal surgery, when we should use it? And over there, they have said we can use it in infrabony defect, in frucation involvement number 2, and with recession defects. All of us know this documentation, we know this research, and then I say to myself, in my clinic, I took it to the next level, and I'm using it also in cases where I have external root resorption, and where also sometimes I need to use flapless technique. Why do we need to use flapless? Because we have patients, systemic patients today, that we cannot treat it surgically. And this material have been proven that can be used also in a non-flap technique. So the patient comes to your clinic, you're doing anamnesis, right? We need to give classification to our patient. What is this patient? Is it a former periodontal patient? Is a new periodontal patient? What is the staging and grading? When we are deciding and we are making the classification of the patient, our goal is to make him healthy. We are the physician of the mouth, and in my eyes, our job, first of all, is to retain teeth and make the teeth healthier so our patient can have a healthier mouth. I'm going to present for you a few cases that I have documented in my clinic. We're going to start from flapless, and we're going to go through infrabony defect, surgical, only Emdogain, then surgery Emdogain with bone substitute, then for mucogingival surgery, and also external root resorption. I developed some protocol in my clinics that works for the past 5 years, and I hope to present it for you today. So let's start with the flapless, Emdogain flapless protocol. What is the Emdogain flapless protocol? When we want to apply this protocol, we have to understand there is an indication. It's not just coming, okay, there is a patient, he has a 10 millimeter probing depth, let's apply Emdogain. No, it has to come after initial therapy. So you do the initial therapy, you do the scaling and root planning, and then you do a reevaluation after 3 months. And if you still see there is a probing depth more than 4 millimeters, and you see the patient has infrabony defect, and he is a systemic patient, and you don't want to treat him with surgery, this is the time you want to apply this Emdogain flapless protocol. So this is the timeline and how you do it. And I want to show you a case of mine. This is a 75 years old patient. He has diabetes and his A1C level was 9.4. He had a pus formation on tooth number 36. He had a furcation involvement, inflammation, bleeding on probing, and he had pain. His dentist wanted to extract this tooth. And I said, wait, he's unstable diabetic patient. Let's try another way. And what we did, I did an initial therapy, scaling and root planning, and then after 3 months, I saw there is still a deep pocket. I decided to apply Emdogain in a flapless way, the same protocol as was documented in the studies. And you could see after 1 year, I took an X-ray, I did my measurements, and you could see clearly that the bone is there. And I measured, there was 3 millimeter probing depth, and the furcation became furcation 1. And what is nice to see that also the A1C level becomes 7.1. I think one of the most important is to emphasize our patient, the systemic patients, the correlation between the periodontal problem and what they have, the periodontal problem and what they have as a systemic. If there is uncontrolled diabetic patient, please talk to him. We can help him to get a better situation with his diabetic and also educate him that it's correlate. So he had to go to his physician, maybe to add some medication, maybe to add some sport, better nutrition. We are talking with patients, and it's important for them to know how they can become healthier. The second surgery that I would like to show you is how we use Emdogain, only Emdogain, and apply it in some cases. So we know that when we have a narrow defect and very short intraosseous defect, we can use only Emdogain. This is by the protocol. So you could see here a patient that I have done this kind of protocol, and at the end of the day, he got a bone regeneration. Of course, you saw here from these amazing colleagues of mine that they have an amazing situation of bone regeneration with Emdogain with a higher defect. This is another surgery that I've done to a patient with a simple papilla preservation flap. This tooth was almost extracted, and he came to my clinic, and then we decided to do this surgery with only Emdogain. And you can see clearly the bone regeneration. It can happen, and the tooth is still there after 7 years. Let's talk about what we should do if we have 15 millimeters of defect, if we have a deep infrabony defect, what we should use. We should take a graft, because the graft helps us to stabilize the wound healing. The graft helps us to stabilize also the clot inside this deep periodontal defect. So you could see here an deep infrabony defect, 15 millimeters with furcation involvement, and you could see the graft that I have put in the infrabony defect. This is a xenograft mixed with Emdogain. By the way, if somebody wants to know, you have to leave it for 5 minutes so the xenograft will absorb the Emdogain itself, and you can see the result of the bone that sits there in the infrabony defect. Those two cases were the same patient documented. You could see also the intraoral photos. You could see the quality of the tissue that we get after a long time. And this specific case was documented in the book of Straumann. And the book of Straumann is here if you want to take a picture. You have a QR code that you can scan and download it to your phone, which you can see an amazing cases of bone and tissue regeneration with Emdogain. Last but not least, one of the last cases, this is mucogingival surgery. Patient on her 60 came to my clinic, was referral from another doctor. She had an issue. What was her issue? She couldn't brush. When she brushed, she bruises her gums, and it's hurtful. It hurts her, and she said, if I have some solution for her, and clearly you can see the recession, the abrasive thing that she had there, and I told her, yes, I'm going to perform a recession coverage, a coronally advanced flap, tunnel coronally advanced, and you could see that we put an Emdogain. They took this connective tissue graft, applied it on the Emdogain. This is a subepithelial connective tissue graft, and after documentation of more than 6 months, you could see clearly the tissue that she got. You could see that the frenulum is no longer attached, and the patient can keep her oral hygiene. This is very, very important. You can brush, and she doesn't have any more sensitivity. And in this video, I want to show you a fast forward of 1 minute of recession coverage. This is using tunnel instruments, preparing a lateral coronally advanced tunnel. Here I'm measuring how much tissue I need to harvest from the donor side, from the palate. I'm taking subepithelial connective tissue graft, placing this collagen cone, suturing it with nylon suture in order to adapt the incision line over there. Then I'm taking EDTA, 2 minutes, washing it, drying it, taking the connective tissue graft, inserting it into the tunnel that I've created, and then apply the Emdogain between the tissue and the root surface. I'm suturing the lateral coronally advanced tunnel, and I'm also applying Emdogain on top of the sutures, and see that everything is stable. You want to see the results? So this is a result that I already documenting it for 5 years. The patient comes every year, so I can document it. You have a Miller class 3, or you can call it RT2. You could see here the bleaching of the roots. The 2 roots are very much buccally, and the invagination of the frenulum. And after the treatment, you could see the keratinized tissue that the patient gets. We know by research that the only thing that can get you keratinized tissue, it's an autograft. This is from the patient connective tissue. Another case, very interesting one, came 2 years to my clinic. She went to perform a recession coverage in another clinic. She came and she told me it was failed. And I could see that she has like a scar tissue on her gums. I told her, wait a second, first of all, I want to check CBCT. Why? Because maybe we can push the root into the lingual area. I went and did the CBCT, and this is what I got. I got a very buccally tooth without any bony envelope, of course, and there is no lingual bone. So what should we do? The only thing we can do is make a recession coverage. And also, if you're wondering if the tooth has if it's a vital or not, just for you to know, the tooth was vital. So I took a connective tissue graft, subepithelial connective tissue graft, dipped it in an Emdogain, applied Emdogain on the root surface, closed the laterally closed tunnel, and this is the results. So I have almost 2 years documentation of this tooth with a recession coverage. This is not a perfect one, but it's a stable one. She doesn't have a probing depth, she doesn't have a bleeding, she can clean, and she's very happy that the tooth is stable and stay there. It's important to mention that this has happened because the patient had a wire that was broken, and when the doctor cemented the wire again, that caused to the root to come buccally, and then she got the recession. So when you have a wire that released from the tooth, please don't re-cement it. Take it out, make a new one. That's better. Okay, this is last case which I wanted to share with you. This is a protocol that I am doing in my clinic for the past 5 years for external root resorption, and I hope soon we're going to document a case series about it. External root resorption happening a lot after, I see it a lot after orthodontic treatment or after a very extensive scaling and root planning. And you could see here a patient that came after 1 year of orthodontics. To her orthodontist, she had developed flaring, inflammation, and pus formation from tooth number 11. And the orthodontist told us, okay, this is the time to go for endo. So she went to the endodontic, and the endodontist did an endo treatment. Still, the problem didn't finish. And you could see here that she has a fistula in the area of the tooth and a probing depth of 6 millimeters. The endodontist sent her to my clinic, and then I told him, okay, we have to open a flap to see what's happened there. And when I opened the flap, I could see cemental tear. Cemental tear are a breakdown in the cementum. That means that through there, the external root resorption is happening. If you want to correct it, you have to take out all the cemental tear. If you want to take it out, you have to have a magnification glasses or microscope to see it. With naked eyes, it's almost impossible to see it. So I cleaned the cemental tear. I applied Fuji on top of it. I did put an EDTA, 24%, waited for 2 minutes, washed it, dried it, and apply Emdogain. The same protocol, nothing changed with the Emdogain protocol. I took a subepithelial connective tissue graft, dipped it in the Emdogain, inserted it and sutured it under the buccal flap, and then I followed the case. So I want to show you from this area, from the area that we had a deep pocket and a fistula on top of it, together with Emdogain and a connective tissue graft alone, you could see the healing. This is a 2 years documentation, no more probing depth and no more fistula, and you could see clearly the keratinized tissue over there. So for me, my take-home message, I want to share with you my thoughts, and I hope you can take it with you home. The first is, use regenerative material. That helps and facilitates your results, your long-term success and results. The evidence give us the back and give us the knowledge to do it with the Emdogain, and it help us to understand how we can do it and perform it better. It's safe. We can sleep at night with this kind of material, and we don't have to worry about it. And last but not least, and this is my protocol in my clinic all the time, I first of all do oral hygiene instruction. I motivate the patient to clean well. I teach him myself. I don't let my assistant to teach him. I'm teaching him. I'm showing him how to brush, how to use the dental appliance in order to keep the results. I'm educating him. I'm telling him about smoking, about diabetes, about systemic disease and the correlation to the periodontal issues. Then I start with initial therapy, doing scaling and root planning. 3 months, reevaluation, and see what is the probing depth now. And after that, if necessary, I'm doing periodontal regeneration techniques. If it's flapless, if it's surgery, if it's doing other techniques, recession coverage, it should always come on a healthier periodontal situation. And by that, I want to thank you very much for coming and listening to my clinical cases. This is my QR code. If you would like to contact me, you can write to me. And I have a YouTube channel called Perio Home, which is a free video documentation of the things that I'm doing. You can go and watch it. So I want to thank you all for coming and listening.
Thank you, Meizi. Great presentation. We don't have so much time any longer. Time is over. So I don't know if you have 1 or 2 questions. Otherwise, I can make a summary. Is there some acute question to any of us? Okay, so the summary would be that we have a material that has a very strong evidence. You have seen it, and we have an evidence with more than 30 years of follow-up. And so use it, select your cases, and be sure that you have a solid scientific and clinical background. And thank you very much for being here. Thank you, Straumann, for organizing this symposium, and enjoy the meeting. Thank you.